I'm Dr. Bill Wyatt, and I want to show you some orthodontic stuff that we've been doing for years. I'm a general dentist that has done nothing but orthodontics since 1970, and this is an interesting subject here, these missing multiple teeth that a lot of people are missing a lot of their teeth, and this is how we dealt with actually 3 patients that we'll show in this whole thing. I'm a member of the American Orthodontic Society, and this is a group of general dentists and pediatric dentists that actually devotes itself to teaching general and pediatric dentists orthodontics. And it's one of the best organizations going as far as teaching this. We have some excellent teachers and an excellent program. We have a board set up way that you go through different steps to learn orthodontics, and then you can take the boards and be board certified in the American Orthodontic Society. So anyway, I want to get on to this case right here now. It was actually done by a team. It was my patient, and I got other people to help with it. I got an old surgeon and also a restorative person to work with on this, and it doesn't last too long here, but let me go through it. It's a young man who came in to me from the town of Glenrose, off about 60 miles away, and he had a real problem here. I don't know how he got referred into our office. Got a kind of a class 3 jaw. Look at it from the front, he is pretty normal facial height, no problem there. I mean, this is good. This is maybe a little bit the way he's got his mouth open there, but he has a real close bite dentally. I'm going to draw on this stuff as we go along and kind of illustrate things. This picture was taken, I took pictures, but I don't know what happened to the first pictures that we had of this young man, but this is after we'd been in treatment for a little while, just a few months. He has a tremendous closed bite. You just would not think, looking at the young man's teeth, would be like this. Now he's missing actually more than half of his teeth, and our objective here is to put the teeth that he has in the best place, the place where they should be, those particular teeth, and expand the jaws, and we shorten the lower jaw surgically, and we put these teeth that he had in the place that they would normally go, and then had bridge work done the rest of the places. The bite, when he opens the bite, there's a gap in here that's quite wide, and these upper teeth actually go down to about there when he closes too. I'll push this back down, and you can kind of see that. They go back down to about that same place. And so you've got to open the bite dentally before you can do anything in here. And so we're setting out to intrude these teeth here. We want to push them down, and we don't bring these up to where these teeth are in contact. The molars and bicuspids all around would be in contact. What teeth he's got over there will be in contact. Then we'll jump these centrals over this, centrals and cuspids, whatever he's got up there. We're going to jump over that. And I tried opening his bite with the blocks in the back, and that didn't work. I couldn't bring the anterior teeth down with the wire, force of the wire. So here we've got, you can see the missing teeth and the many deciduous teeth in here, and same thing on the bottom. So here is a Panorex that we took in 1988, and when you could actually look at the Panorex on a view box, you could see it. It's not the best Panorex in the world, but we kind of drew out a plan for what we were going to do on this. Now here we are with the intruding arch wire in, and we had these blocks kind of opening the bite. You see the teeth are up here, and we've made some progress. We've got these teeth, we're pushing them out with springs and everything, and we got the upper teeth out over this, and you can just close down this far. But this my intruding wire here is not strong enough really to bring this down. So we went at it a different approach here. We're gonna put the acrylic block in the anterior part of the mouth. So that's what we actually change that over, and we'll put something up here. Take this out right here. Now, same thing over here. So we removed that, and we went in and put the anterior blocks in this part of the mouth, and you can see the big space we've got there. Put that in and marked it, and forgot to erase it. So anyway, that's what we're using, an anterior block up here. Now, as this intruding wire forces these teeth down, it picks these teeth up right in here. And the occlusion on these teeth here, and no occlusion back here, these teeth tend to go down, and these molars are going up. So we flatten this out to where these bicuspids would be meeting at the time the anterior teeth were in contact, and we could jump them over on the labial side. Same thing over here. Now we jump over a lot of time here. I didn't get to take as many pictures as I would like to have taken, but you can see his occlusion was just right up here in the front. Now if he'd had a bad TMJ, you couldn't have done this. The force is here, and then it's on the condyles back there chewing. So if a person has a real tough jaw joint, you can have them eat on the front and nothing on the back, let the back teeth come together. So anyway, this is what we did, and had no problem with his joint. And I know the guy today, who's a good friend of mine, and he has all these teeth still, and this is 2016, and at this point, this was 1980, 89 right there. It started in 88. So we're going to jump over some of this. You see, that's what he chewed on right up here in the front part of his mouth. But it doesn't take very long for the teeth to go together back in the back. Okay, we got him flattened out, and the restorative guy, we had him spread out and put the teeth where they could be. And the restorative guy made some preparations on the teeth and put some wax up, and we looked at it, see how it's going to be. The old surgeon checked it out and got it going. And so we had the maxilla forward and brought the mandible back and had him in a good class 1 relation. And this is not a perfect class 1 back here, but we fitted in there to make the teeth fit. It's not ideal. It's pretty good here and here, but this bicuspid is not big enough here. In other words, the bottom teeth really, bottom molar normally comes out like that, you see, but they've bridged it up and made it where it fits tooth-wise with the way his jaw was going. The other side is very similar thing that they did back in this area around the molars, but it worked out quite good. Sorry for the cough. Okay, we went ahead and made some temporary deals. The restorative guy, we put braces on them to keep it lined up and everything. And then he had the surgery. I think he's already had the surgery now, shortened the jaw and brought the jaw back. Here it is set up on the typodont. And we had the bridge work made up prior to his surgery. So anyway, we got this back in place good, and the guy's jaw is back now. This is a good bit after the surgery, and the face looks good. The teeth look awful white to me, but they're still looking good. Now this is 12 of 89. This is later when these bridges are in the mouth now. It's fitting good in the mouth with the bridge work, kind of like it was with the wax up. This is not quite as fitting as interdigitating as good. I saw the guy, I took some pictures of him in 94, I think, but there's the bridge work in the mouth. And you can see where the bridges are fitted together at that point. This is that old Panorex, which is not too good, but we'll show the next one here. So on this Panorex, you can see that he just has very few teeth. On the bottom arch, I don't really see but about 5 teeth in there with the bridges on there. And the upper's got about, looks like about 8 teeth in the upper arch. This is an old type Panorex that we put together and have a bite to them. And if you look close, you can see the screws. See that where the jaw was sectioned. Same thing over on the other side. And the facial appearance, you got a good smile line, and looks quite nice, even though I felt like the color of the teeth wasn't the best in the world. Now, this is 1994, and I saw him sometime about 2010, I believe, something like that, and looked at him. I may have taken some pictures, but I don't have them here to show you. They've got a little plaque that he needs to have cleaned out of there, and up here but the teeth are holding up good. In fact, I saw him just a few days ago, and this is 2016. And we did this in 1987 and 88 and 89, finished him up. And this is 94, but he's still got them, and they're still functioning good. So I'm going to encourage people, don't jump on some case like this to start with. It's just something else. But if you get in the American Orthodontic Society and can take the courses that we give, you can learn to do things like this. You have to work with a surgeon, but the surgeon doesn't care if you're a general dentist or a pedodontist. He just wants somebody that can do the orthodontics that he needs done for him to do the job that he needs. And then you can have somebody, of course you might be the one that would do the restorative work yourself, or you can get a restorative man to do it and you just do the orthodontics. That's what I've done for this going home over 40 something years now, 1970. And that's the lower arch. You can see it's just a solid mouth of bridges. And I'm going to end this at this point and pick up with another phase of this later on down the line. So we'll close it out now, and I'm going to stop it.